Dr. Bhandari played a key role in advancing India's medical training as the country entered the 21st century, serving on the boards of multiple journals and as the president of the several medical societies. Dr. Bhandari exerted vast influence on the practice and teaching of medicine, especially the development of a residency program for the specialty of urology. His leadership also includes a founding role in the production of the Medavarsity.com, an online portal for medical education. At the Vattikuti Urology Institute, he has focused on developing the clinical research program and improving the use of biostatics in medical research. He is also actively promoting the development of robotic surgery in Indian urology and has been the backbone of the recently established Robotic Surgeons Council of India. Friends, I think Dr. Mahendra Bhandari is going to be with us on Skype, and very soon you will hear him.
Good morning, Dr. Dogra. Can you hear me?
Good morning, sir. Nice to hear your voice. Yeah, we can hear you very well.
Okay, my slides are seen?
Yes, we can see them.
Okay. Thank you, Dr. Dogra. It was wonderful. I could recognize your voice, and thank you very much for a generous introduction. And that is what is a friendly bias comes in whenever a friend is sitting. Ladies and gentlemen, a very good morning to you from Miami, Florida. Weather is totally different here than what I anticipated in Chandigarh at this point in time. First thing, I would like you to relax. You can loosen your seat belts because transplant is complete. Rajesh Alawat has already done the difficult job for me to be over. This gentleman is Arnold Pudge, who was professor of ophthalmology at the Johns Hopkins Institution and University. You would be wondering why I am bringing an ophthalmologist to a urologist on transplant meeting. He is the person who identified and observed post-war in 1950s the cause of blindness in prematurely born neonates because of the hyperoxygenation. And all of you would know the condition retrolental fibroplasia, which was almost an epidemic at that point in time, and almost it is said that 10,000 children were blind because they failure to thrive, so they would be given with oxygen, and it was totally a counter-current thinking for when he came. The whole ophthalmology world was against. NIH refused to give him a funding, so he had to borrow money from his family to do the first study because everybody said that he would kill more children than save them from blindness. Ultimately, he was named as, made a major difference in the quality of life and prevented children from getting blind. He averted the epidemic of blindness at that point in time. What this story shows us, there wasn't much instrumentation, gadgets, technology. It was a very simple observation. But the significance of observation is utmost. Even in today's digital world, the innovations are judged by the significance, not by the complexity of processes. There are two kinds of innovations you can have. One is incremental innovation, which I'll be talking what Rajesh Alawat talked about. You improve the quality of patient life through a kind of treatment or a surgical procedure, reduce the morbidity, minimize mortality. And other one is a disruptive innovation. I would very easily dub this as a disruptive innovation. Hence, all of you would agree that innovation is something which is an accident, which is everybody's prerogative with senses to observe and find a solution. This is yet another ophthalmologist. I have a fascination for the ophthalmologist. And who would not know the story of intraocular implant, which was done first time by Sir Harold Ridley on 29th of November 1949 at St. Thomas Hospital. Why I'm bringing this example is for the reason that Ridley did not solve the problem of aphakia. He introduced a new concept of biomedical biomaterials to be for the first time to be used in human body. I don't have to tell you, there is no specialty which doesn't use biomaterials in the body. And this is the story that he was also a war veteran, and he was used to treat the war victims. So Flight Commander Gordon Moose, who was on right side on top with scarf, cleaver, had an air accident, and the perspex sheet of the cockpit got into his eyes. He was taken to Ridley because Ridley was used to manage such injuries, and it stuck in his mind because he followed Cleaver for months and years to observe that the perspex sheet in the eye has not caused any untoward reaction. And that gave him an idea that, well, one thing is clear, that appropriate biomaterials can be accepted by human body without any reaction. That day onwards, his solo thought process started working on replacing a lens with a biomaterial. The story was completed by this curious resident who was watching Ridley doing a cataract surgery. Once he removed the lens and he was closing the section, then this resident, "Sir, you have forgotten to replace the lens you have removed." And that firmed up the idea that he has to do something. And then he worked with the Rayner company and developed intraocular lens. Look at the so the basic point is that these discoveries or innovations don't confine to a particular specialty or the silos which we have created. They become commonly used and they get into a process of co-creation. And that's why it's very important for us to dissolve these specialties and subspecialties at some point in time, dissolve the wall, and have a free cross-pollination between the specialties to apply one application to the other for the patient benefit. One problem about innovation, that all innovators in the history are ahead of times, and there is very little endorsement and support. Most of the time they face fierce criticism from peers and colleagues. It is kind of an uncommon belief at that point in time, and it is the strength of belief or the conviction of an individual which sails through the whole idea into a concept, into a developed product which would lead to benefit of the life. And this is what Henry Ford said. If I had asked people when he was coming up with the Steamobile, the first engine, if I had asked people what they would like, they would have said faster horses. So this is a problem, and that's why every innovator has to really put up with it and accept it, that they would not be accepted. Now, we have seen these two examples, and there are umpteen examples where the whole concept, the pivot of the whole problem is an individual. From individual, he creates a team, because you see that in case of intraocular implants, Ridley was a wonderful, one of the eminent forefront ophthalmologists, but he had no idea of the biomaterials and the lenses in the eye, and so he had to team up with the people. So they create a team. This is a common algorithm for any innovation. Then they have to train the team for each other's discipline to work in a cohesive manner as a force, and then there is a collaboration. Most of the talk would be harping on something which should be very common, but which is very rarely seen. The key to any innovation, including kidney transplant, was a collaboration, and the boundaries of city, state, institution, department are all merged into a global collaboration. This is a very interesting slide. Mainly, I have made it for younger urologists and transplant surgeons. I anticipate there would be a lot of postgraduates and residents in. I want to tell them that in India, we are very obedient to our seniors and doctors. That is a good quality. But don't stay as residents for the rest of the life. Behave as surgeons. This is what this slide shows. The pair on the left-hand side is Norman Shumway from Stanford University, one of the most eminent cardiac surgeons, who was acclaimed to develop all the techniques for heart transplant, which were used by Krish Barnard to do the first transplant in 2001 at Cape Town. Truly, the developer was Richard Lauber. Whole world of heart transplantation was struggling with the technique of heart transplantation, but it was Richard Lauber, who was assistant or trainee to Norman Shumway, developed a technique in mongrel dogs to transplant a heart by using the chambers, and that first time he could keep his mongrel dog surviving, 2-year dog surviving for 8 days. Krish Barnard was also working on heart transplant, but he had no way. He had failure in establishing anastomosis of different kind. Incidentally, he was visiting Norman Shumway, and he watched Richard Lauber doing his technique, and that ultimately paved way for a very successful heart transplant. On the right-hand side is Stanley Dudrick. You would not, probably many of you would not know, and Jonathan Rod. Again, Stanley Dudrick was a resident to Professor Jonathan Rhodes, and he was the one who developed the total parenteral nutrition. If you look at JAMA in 1986, 4 significant advances in medicine, and one of them was total parenteral nutrition, which cuts across all the disciplines. And if you see 3 surgical important things, one of them is open heart surgery, organ transplantation, and total parenteral nutrition. When you see 4 things, in the total medicine is anesthesia, asepsis, and antibiotics, and one of them is total parenteral nutrition. Now, let us come to our story of developing a kidney transplant. Most of it has been covered by Rajesh Alawat, very, very ably and very clearly, and I'm sure you would be able to watch him in action to understand completely what he was talking about. Why did we think of a kidney transplant? It was a crazy idea to begin with, and when I was talking to Dr. Menon, we have been talking about it, but as a transplant surgeon, to be very honest, it didn't make any sense to me that having made an incision, why the hell you want to close the incision and use a robot to do it, because it's pretty simple standard technique. But then we looked at what is the current status, why should we do it? Immunosuppression has solved a lot of problems in transplant, but still there are complications in terms of lymphocytes. Maybe you don't have to see the lymphocytes in terms of numbers that only 5% of the people, or for that matter, wound infections or other infections. Look at the magnitude, and there is a way to classify these complications, not by Clavian, by accordion method, that the magnitude of lymphocytes, symptomatic lymphocytes, is very huge, is very complex to manage these patients. So we were focusing that since we will be putting kidney intraperitoneally, maybe we would be able to overcome this and the wound infection. As Rajesh has already told, that we were not the first ones, and we are grateful to these people who thought of using robot for kidney transplant, because most of our techniques were built on their failure, and we built our mission that we will, if we use the robot, we'll use the robot for everything possible and not use open incision for doing part of the technique. The secret of the whole dissemination of the procedure is the data. And I can't overemphasize, it matched, our project matched in 2012 with a very bright young fellow who joined us. He's an All India Institute graduate, and he joined us as a fellow. He helped in maintaining every bit of the information of what we did. All the videos were with him, and ultimately it helped him in getting a residency at the Henry Ford Hospital, because he was the one who outclassed all the fellows in terms of number of publication and significance. So the point here is that we do innovations every day in operating rooms, but they are all anecdotal until, for the rest of the world to follow, you have to meticulously maintain the innovation data and present it in a form. It's all about numbers. Then coming to the collaboration, I think we had thought over a lot and contacted everybody possible in the world. Whoever had an experience of using vascular anastomosis with the help of robot, and we ultimately ended up having a partnership with Ohio State Medical University, who gave access to their fresh cadaver lab. And here is Bob Banson, who is the chairman of the department, Dr. Menon Parfait, who was a wonderful guy in the operating room assistant, and he would never say no for anything we wanted to have. And then we had Ronnie Abaza, who was there at that time, who had done one auto transplant. We contacted Jill Anati, and we wanted to bring Jill Anati to do the first 7 transplants with us, but unfortunately, because of some visa issue, he could not make it. Rajesh has already told what we developed was gel point, intracorporeal cooling, arterial and venous anastomosis, docking and de-docking of the robot, positioning of the patient. Everything was developed, suture material, clamps, everything was done to flatten the learning curve. This is what Emil Fischer said: the scientific progress is no longer determined by brilliant personal achievements, but rather through collaboration with teams of masses. So only one lesson I would like you to carry home is, if you want to really make a major difference, think of collaborating with giants who may be more intelligent or more technically savvy than you. It was not the first time. Vattikuti Urology Institute in Henry Ford Hospital, they have a culture of innovation which is documented by this slide. 2000, first time they used the robot in the right way by developing Vattikuti Institute prostatectomy. Then robotic assisted cystectomy was done in collaboration with Mansoura and Mohammed Ghanim. Then Dr. Menon developed his veil of Aphrodite, the nerve-sparing robotic kidney surgery, partial nephrectomy we did in 2006 and 2007, developing the model at the what you call Sunnyvale, and then we went to Malaysia to do the first clinical cases in partnership with Shahabuddin and his team. Then we did the Henry Ford is perhaps one of the only institutions where they don't use any urethral catheter for the robotic, after robotic prostatectomy. And then gel point and ice was done as a stage 0 for ideal. And then last in the series was robotic kidney transplant. Rajesh has already talked about ideal. I'll only talk of something which he has not mentioned. Ideal framework was developed by McCullough and at the Balliol Institute, but it was totally theoretical. No surgeon followed this, and hence we found a ready collaboration because we had a challenge to do a safe kidney transplant, and we were looking to develop a technique which would be developed in an organized manner, and we followed the ideal technique. He has already talked about preclinical simulations. Now, we published this paper before actually we launched on robotic renal transplant. We developed regional hypothermia, and Wuju, our partner present, published it in BJUI to prove a point that local eye slush doesn't cause any systemic hypothermic effects on the heart or the cardiovascular system, and it can be safely used, and it maintains the core temperature to the desired level. Then we have already talked about the gel point, developing techniques, Rajesh has talked. Then begin our phase 1 to 2, when we did 7 cases at 2 places, and that was exactly as guided by the McCullough's ideal technique. And this was the team we spent. Ronnie Abaza is in middle, close to Dr. Menon and Rajesh Alawat. And then we did 7 cases there. And then we went to IKRDC. They were our other partners with Pranjal Modi. We did 7 cases there. And then, now it's very important to talk a little when you're talking of surgical innovation about the learning curves. Learning curves are formed in 2 situations. When a trainee learns a procedure, when would you call a trainee that he can perform the procedure with himself? So A to B, if you can see, is the period when the training is under training. At B point, you can say that he can perhaps perform the procedure with proficiency without any harm to the patient. Then there is a little lag period later on, and C, the curve starts getting plateaued. And like surgeons like me at E, there is a decline in the learning curve because of your vision may get shortened or the reflexes may be slow. But the trouble with the learning curve is that there is no one learning curve for a procedure. There are controversies about learning curve, and in fact, learning curve has not been applied even for open surgery. It has been used for laparoscopic surgery. Now, take radical prostatectomy. There are learning curves for oncological margins. There are learning curves for potency and continence. There is a separate learning curve for complications. So what we decided was we wanted to control the procedure during the progress of the procedure. In the current scenario, you train an individual and then you evaluate his surgery, but the damage is done during the intraoperative period. So we were looking for some objective way, and Akshay Sood could find a reference of the industrial processes which are being controlled by Shewhart's charts, which are mathematical models to see that, and we used the reference values which were standard, gold standard in literature, like what you call anastomotic times, cold ischemia time, rewarming ischemia time, and things like that. And we use them for all these. Sorry. So we had Shewhart charts, and every procedure was controlled. And if you see that whenever the surgeon crossed the limit where there was a damage, we did an intervention. In this case, we put extra ice. Or if the surgeon was not very proficient with handling robot, we had another surgeon who was better, we replaced it. And hence the point I want to make is that all the procedures were controlled. A very strong safety net was built because we were aware of the fact that we were dealing with very highly reputed, high volume centers wherein one untoward effect on one of the patient could have jeopardized the whole life program. So then similarly, we did the cumulative sum things, so cumulative graphs. Again, it's a mathematical model, and what you can see that the novice surgeon would have them, but still they are within the range of safety. But unlike the competent surgeons, they maintain almost a streamlined kind of thing. So this is a very good way to monitor surgery during procedure. So then to B to 3, we did a prospective non-randomized study between 13 and 14 at Rajesh Allawa Center. He has already talked about this, but just to give you some data which he has not mentioned, maybe he'll give you in some of the talks or on your questioning during the surgery. But he, during this period, Medanta had done 511 transplant, of which 429 were accepted for this comparison, of which 79 were robotic and 350 were non-robotic. And the system was all eligible recipients were offered option robotic kidney transplant offered to consenting recipient, because there was an additional cost of 100,000 rupees in India for that, and economic factors are very important. I won't waste your time. Donor parameters were all matching. So what was the benefit? Clear, significant benefit in blood loss and smaller incisions, no big deal. You can see that it did pay a big benefit for the patients who are younger girls, unmarried girls, and young boys. There was practically, virtually, we did away with the scar because of this stretchable retractor. Pain was another significant thing. The anesthesia people from Medanta has published a paper, and they, according to them, the analgesic intake or giving continuous epidural was totally abandoned in these patients. And the pain score was, we interviewed the patients, which showed that they were more comfortable in comparison to other patients in the board. Yes, we did take more operative time, but that wasn't a big deal, which improved with the flattening of the learning curve. Only thing was simply because we had to use extra ice, and we had very well-tested safety measures to make sure that the ischemia time doesn't affect the graft function. Of course, ischemia times were longer. Again, they were not, it didn't affect the graft function, which you will see. And anastomosis times were, of course, much better with the surgeons to use the needle holders, which had 7 degrees of freedom. Functional outcomes, non-inferior. It didn't make any difference in terms of up to 6 months follow-up. This paper is under publication. Where did it make a difference was, you look at this, is robotic kidney transplant, 79 cases, no complications in terms for 6 months, whereas 17.8% of open cases had lymphoceles. And similarly, medical complications, though not like graft biopsy related complications, were very few, and otherwise rest of them could be matched. Graft and patient survival, you can see that KM analysis was good. The outcome of this collaboration was enormous, and we had 11 publications. 2 of them are still in process, 3 book chapters, and they're pretty global, and you can see that they are very high-end journals we published in. Biggest advantage for us Indians, when I'm talking to you guys, I am an Indian, and I would always remain to be an Indian, and it was a dream coming true when we re-exported these procedures from India to overseas. We did try honestly to do it first in the Henry Ford, but we were not able to move to Boulders because of the regulatory things. But after this, Rajesh Alawad is courteous enough to visit to Henry Ford and have our robotic program move, and they have done close to 6 patients. He has already, several teams have come and visited. Already 2 centers in Spain and 1 in Turkey have started transplant program, and we are hoping that centers in England and other centers in the United States would pick up very soon. Now, last is a shameless marketing slide for Vattikuti Foundation, because the whole project was funded by Vattikuti Foundation, and it is an invitation to all of you that Vattikuti Foundation's focus is only 3 areas now. We have focused on 3 areas. One of them is innovation, like kidney transplant. Second is educating and creating young, bright, very competent robotic surgeons in multidisciplinary robotic programs in India. And then we are focusing on creating a database which we call the Vattikuti Collaborative Quality Initiative. Now, I have excited you enough to be leaders, but mind you, the first quality of leader to be a terrific follower. Thank you very much for your patient hearing, and I would be very happy to answer your questions. Thank you very much.
Thank you, Professor Mahendra Bhandari. I could hear the applaud from the audience, and we enjoyed your wonderful talk. We know you are a teacher of teachers. We have no doubt about your capabilities and achievements, which you achieved today is really unimaginable. We have all got a high regard for you. And thank you very much for taking your time and keeping you awake late in the evening there. I think you must have been awake. What is the time there right now, sir?
It is 11:30. 11:37 yes, to be precise.
So we can see, so such is the commitment at your level that you are so committed. So thank you very much, sir. Have your nice time and dinner, and good night.
Thank you very much.
We'll catch up with you later.
Wonderful to be with you. I wish I could have been there to physically present, but I must thank Dave and Manjeet and team to bridge this virtual gap between Miami and Dave is in Detroit. I am in Miami. Dave Minhard is my eyes and ears as far as the video editing and transmission is concerned, and Manjeet did a great job. We rehearsed yesterday, and Dr. Mandal had his trepidation. I would end without disturbing your rest of the program, thanking Dr. Mandal and Ravi not only for inviting me, but being true to my first visit to them when I incited and excited the then director to have a robotic program at PGI Chandigarh. I'm very happy that they have a very vibrant program, and I'm looking forward to many more contributions in the field in future to come. Thank you very much, and very, very good morning.
Good night.